I'm gonna go ahead and start with the easy one, peg tube meds, right? That's pretty easy. So we're gonna go over that one first. And then since Woom's sitting here, I'll go over that next. And then I'll probably take just a short break. And then I'll go into trach and Foley. And then we'll do sub-Q and IM injections after that. Sound good?
Yeah.
Okay. So let me just first tell you that I'm not reteaching this to you because I know all of you have had this before. So I'm not going into, when we talk about, for example, sub-Q and IM meds, I'm not going to go into detail about what needles you use, what sites. I'm really just demoing the actual skill to you. Okay, so I'm not going to go into detail about every little part of it because you should have that already. I'm basically just going to re-demo the skill to you so that you know what to do in your checkoffs. If you have questions, please wait until I completely demo before you ask the questions so that we don't get sidetracked on the process. And in between each one of these skills, I will let you ask questions, okay? Keep in mind that realistically, ATI, your instructor, me, the papers on there, they're all going to be slightly different, okay? There's not a way that every nurse comes in and says, okay, step 1, I ask the patient's name. Step 2, I do this. Step 3, that's not realistic, okay? The purpose of skills is to make sure that, 1, if it's a sterile skill, that you keep sterility. If it's not a sterile skill and it's just a clean skill, that you're doing the steps appropriately for patient safety, okay? Policy sometimes will, depending on what institution that you work at, policy sometimes drives the way we do things, okay? So for example, sometimes you'll see 15 mLs can flush after medications, but we're teaching you 30, okay? It just depends on the policy, and it just depends on, you know, in essence, who's telling you. So 15 is okay, 30 is okay. It's not like there's a magic number out there that we have to do. The purpose of it is to make sure the line is clear, right? So the purpose of flushing, you're going to look at your line and make sure that you don't feel anything, that you don't see anything. Same with trach. When we're suctioning for trach, it's not, okay, how long do we let the water suck back up the secretions that are in the line? Well, it's kind of common sense. Look at your line. So I can't give you a magic number, suck up 10 cc's, because there isn't a magic number. It's look at your patient. Every patient's a little bit different. When we talk about IM and sub-Q injections, sub-Q is 45 to 90 degrees. That's what you go in, but it's based off the patient. If the patient is a very small patient, that 45 is what you're going to want to go in. If the patient is a little bit larger patient, then a 90-degree angle is probably going to be your better bet. Same with needle size. If you have this big muscular person that comes in and you're doing a deltoid injection, you're probably going to want to use a 1.5 inch needle versus a 1 inch needle. So it's all based, that's why there's so many ranges. It's all based on your patient, and you have to actually assess your patient to be able to determine what number, in essence, that you're using as to whatever we're doing, whether it's trach or peg tubes or IM injections. You have to look at your patient, okay? As long as you hit in the range, you're not incorrect, all right? So don't like hone down on, is it 15 or is it 30? Is it 1 inch or 1.5? Don't like worry about that. Just know that there's a range, okay? All right, questions before I start? Okay, the next thing I want you to understand is the first part of your checkoff sheets, I'm not gonna go through every time. We're not gonna check the patient, we're not gonna check the orders, we're not gonna provide hand hygiene, we're not gonna do all of that because I'll be here till 4 o'clock today going through these skills with you. So we're assuming all of that's already done, and we're gonna jump right into each skill, okay? You guys, any questions before I start? All right, okay, so first thing we're gonna do is peg tube. So when you go into a patient's room and you're gonna be providing peg tube care and providing medications via peg tube, you want to make sure that you have some type of fluid in a container to use. You might see ones that look like this. You might see the actual bottle sitting there. You might see syringes that are put in together like this, or you may see them already out. Some nurses like to give their medications and their boluses by gravity, and some like to push. So it doesn't matter the process, it's whatever you feel comfortable doing. When you are giving meds, liquid meds go first, followed up by your crushed meds. You want to make sure they are very finely crushed, okay? It's going to make your life better if you're taking care of this patient for 12 hours, because when you go back in a few hours to give more meds, you're going to want to be able to push them, okay? So you want to make them very, very fine. They're almost like a powder, okay? The crusher and the cutter is typically specific to a patient. If it's not specific to a patient, there are places that use them for multi-patients. Just make sure that you rinse out the residue that's in it. In between giving meds, you don't necessarily have to rinse this out. Okay, you can just kind of leave it. You're going to get everything you can out of it, and then whatever the residue is left, you just pretty much leave it. Okay, I had lots of nursing students ask me that question, so I thought I'd just bring it up. When you're crushing meds, I'm going to show you about how fine this should be. Keep in mind, these are Smarties, so they crush a little different than your pills do, especially if you have pills that have some type of coating on them. If they have coating, they're hard to crush, so you have to kind of really do this for quite a while to get it crushed up. If you don't think it's crushed up enough, don't give it. Keep going. If it takes 5 minutes to do this, that's what you need to do, because it's going to be way better off. Okay? You don't want to have to call the physician and have them come and put a new peg tube in. Sometimes that means they can do it at bedside, and sometimes that means that they have to go back to surgery. So either way, we don't want that to happen. So it should be pretty fine. I mean, it's literally like a powder at this point in time. I know it's hard for you guys to see, but it's literally like a powder. What I do is I go ahead and put it in a med cup, and I will go ahead and put some you don't need a lot, just a little bit. I have about 10 or 12 cc's here, and it can start, kind of swirl it around a little bit, can start melting per se while you're taking care of your patient, getting your patient ready. Okay, so I just let this sit there where I can see it. Always take a towel in, especially if you're new, because at some point in time you will get gastric contents on you as a new grad. I did it, so it's just inevitable that it's going to happen at some point in time for you. So just make sure you have a towel there so it's not all over the bed and you have to change the bed and the patient's gown. Okay. A lot of times peg tubes will come up onto the unit if they're freshly placed without the stopcock on them. So it'll just be this white part, the tube part only, and it'll just be plugged. So the stopcocks are in the med room usually, and sometimes we have to actually change them out a little bit too, because they get kind of corroded or they are not working as well as we like them to, so sometimes we have to change this out. Don't think that you have to call a physician to be able to do that. It's in the med room. Just get it and do it, okay? Typically, if the patient is hooked up to tube feed, it's going to be from this site, all right? So I will generally always use this side of the stopcock, even if there's not tube feed hung up right now. Okay, it's just habit. I just always use this side. Okay, you can use either one though. Knowing how the stopcock work is the hardest part of this job, right? So the off is where it's going to be, it will not flow. Okay, so if the off is pointed towards the patient's tube and you put fluid in, it's going to go right in here and right out there. All right, if you move the off to here, whatever is in here is going to flow straight out or go straight in. Okay, if you move the off to here, then what's going in here is going to go through there. Okay, does that make sense? So just learning this is like half the battle. Okay, because everybody turns it the wrong way, and the next thing you know, you have fluid or medication that you just pushed or something flowing out. So just kind of look at this and make sure you understand it. So if it's off towards the patient, which is what we want right this moment, we'll go ahead and check for any residual. Policies, different places are going to be different as far as when to notify the physician, okay? So you're going to go ahead and connect your syringe, and I always make sure that it's nice and tight, okay? Because these syringes have quite a bit of force on them. And if you start pulling and it comes undone, again, you've got a mess. So once you're syringe is connected, go ahead and move it, the off, to the part that you don't want anything to go to, and see if you have any type of residual. So this patient has about 35, so we're okay. So we're gonna go ahead and push it back in. Make sure you move your stopcock to the place that you need it to be. Unconnect. Go ahead and get your medication. And again, you can do this by gravity or you can do it by using the actual plunger. So it's whatever preference is, okay? I just like to use the plunger as how I was taught 100 years ago, so that's just the way I do it, okay? So once you have all your medication, don't worry about getting the air out, okay? And the reason why I say that is we don't want air in the stomach, but at the same time, when you invert this, you can push it to where you just stop with only the fluid. So a lot of students get hung up on doing this like they're ready to give an injection. You don't have to do that. Just go ahead and connect, air or not. Move your stopcock to where you want it to be. Invert your syringe so that you're able to see your fluid versus your air, and just push your fluid. Once your fluid is pushed, your stopcock back to the appropriate place and unconnect. Okay. Then go ahead and flush. I'll draw up 30 cc's here. And again, it's not, you don't have to be like, oh, it's got to be 30. Only find 30. That's not as important as the process of making sure everything's out of the line. And it flushes without any resistance. And that is PEG tube. Questions? Yes?
In the skills demonstration, are we just going to do one med or will there be multiple meds?
Honestly, I don't know how the skills checkoffs will go because it's driven by your instructor. So some instructors are a little more creative than others, so they may want you to crush up more than one med. So I can't answer that question, unfortunately.
So if there's more than one med, we just keep repeating the steps with the...
So if you have more than one med, I would crush them all together and then put them in your med cup, suck them up, and give them to them. Unless it's indicated that they can't be given together, but I haven't seen that very often, okay? In a real life setting, there's no way that nurses can crush a med, do that whole procedure, get the next med for 25 meds that this patient has. It's just unrealistic. You'd be in there all day with that patient, okay? Just realistic. Any other questions? Yes?
With the stopcock, so you said you prefer to use the one on the side. Mm-hmm. They're both equally
correct.
fine. Okay.
Yep, that is correct. So you can use either one of them. It doesn't matter. I just always, this is my go-to side just because generally speaking they're hooked up to 2 feet a watt. So I just went to this automatically and I just use this side all the time. Just because I think it's more about moving that stopcock and I know where I'm moving it each time. Or if you start doing it over here sometimes and here over here, sometimes you'll end up seeing that you're not as coordinated with this. Okay, so it's just preference.
So in this case, you've got the off pointed towards the feed side, right?
So at this point in time, I have it off towards the patient. So if I put a syringe here, it would be dumping it out here for me.
Okay, but when you'd be giving them, you'd have it, if there was no feed.
Yes, the off would be here.
Okay.
Yes, correct. So if you haven't had a lot of experience, this seems like a really easy skill, but this is the hard part of it, is this moving this, even though it seems like it's really easy. Just go practice this. Go get your syringe full of water and just practice and make sure you kind of get the concept, because this concept is the same with IVs, and you're going to learn that next med surge. So get this concept down of off and on now, because you'll need it for IV stuff too. Okay? And A-line stuff. So Anybody else have any questions about that? All right, so we're gonna move on. And I'm just gonna keep these gloves on through skills for a little bit, okay? I'm not gonna change them all the time. Can everybody see if I'm here? So the first thing with wounds is you want to make certain that you're setting up your sterile field in a location that maintains sterility. And what I mean by that is it needs to be waist level. It shouldn't be below the waist, so you shouldn't have your table down low. You would want to potentially raise the bed. I'm going to leave it down so that you guys can see it better, but you would want to raise the bed to your level. You would also want to make sure that wherever you're setting up your sterile field, that you're not turning your back on your sterile field or your patient, because at some point in time, they're both sterile, right? So if you're over here doing something and you're turning, you're losing your sight of this sterile field. So just make certain that everything you need is right there, okay? If you start a process and you forget something and you're in the middle of it, that's why we have call lights. So hit your call light, ask someone to bring it in for you to instead of having to kind of start all over. If you've just started your process, then you probably could do that. But we have call lights for a reason. Get some help, okay? All right, so you're gonna need some type of sterile field drape. You're gonna eventually need an ABD pad. You're gonna need some cotton tip applicators, and this is all based on the fact that I already know what this wound looks like. Every order is gonna be a little different. You don't need this supply for every single patient that has a wound. It's just what the orders are. I know this is a wet to dry dressing, so that's why I'm gathering these supplies. You're gonna need some gauze sponges. You're gonna need some Curlex, and this would generally be in a sealed bag for you, but I didn't see any that were still sealed. These, again, will be in a sealed container for you. So you need scissors and forceps. The ones we use here don't want to grab this very well. So if you're going through your checkoff and you're really struggling to get it out, just verbalize to your instructor that these are a little worn out and they don't want to grab anymore, and they'll be okay with that, okay? Don't harp up on, oh my gosh, I'm sweating now because I can't get this out. Just move on. You're gonna need some tape. You're gonna need your packing strips. You're gonna need your normal saline or your sterile water, whatever's ordered. You're gonna need some type of bowl, and this will be again in some type of bag so that it's sterile, okay? So I go ahead and don my clean gloves, and at that point in time, I'm gonna go ahead and remove what's on the patient. You wanna be careful when you're taking off tape. This patient's skin is already compromised, so we don't wanna cause any more tears. In every layer that you pull off, you should be assessing the color, the consistency, the odor, the amount, okay? You should be looking at that. And when you go to pull this out, realistically, it should be dry. Right now, this one is soaked because somebody just did it and it's not a real patient. So when you pull this off, you're really wanting to pull that dead tissue off of there. That's the purpose of wet to dry. It's wet when you put it in, it dries between the next time that you're scheduled to do it, and then you're debriding that material that is not wanted in this wound. Okay, so you're gonna see a little bit of bleeding. You're gonna toss this in your trash can. Sometimes I will take in an extra set of forceps because it's a little bit difficult sometimes to get in there and pull out the packing strips, especially if somebody didn't leave you a nice tail. Okay, so I always tell my students, leave a nice tail so that they're able to easily pull it. They don't have to dig down in there to get it. But I always just take an extra set in with me because at this point in time, I don't want to have to say, oh, I need an extra set now. So, and I have to call. So I just take them with me. I can always take them back, right? So go down in there and go ahead and remove your packing. Take a look at about how long it is because that's how much you're going to need to repack or around there. Look at the color consistency again. And this patient has 2 tunneling areas. Okay, so you're looking again. Okay. At this point in time, it's ready to clean and measure. Okay, so you can use many different types of devices to measure. There are rulers, there are clear plastic, like circles that have rulers on them. There are rulers on your cotton tip applicator, so whatever you want to use to measure. You're going to measure the wound. You're going to be charting on that. You're going to note any type of undermining. You're going to note any type of tunneling. Okay? You can use your cotton tip applicator to help you determine that undermining by going around the wound and measuring, and the tunneling by actually going down into the tunnel area and then measuring. Okay? A lot of nurses will just use the normal saline that's in for like IVs, it's already pre-filled syringes to clean the wound. Some will use your sterile water or normal saline with these containers to irrigate the wound. Okay, it's really just a matter of preference and orders. So we're going to go ahead and just use pre-filled syringes right now, and we're going to irrigate that wound, making sure that we get that wound nice and clean. Okay, we don't want to start with a dirty wound. We want to get it as clean as we can. So removing any of that slough that's on there and getting it completely clean. You can use your gauze sponges that you have to help wipe that out if you need to. You can also use cotton tip applicators if there's like an area that you really can't get to very well. You can use those to kind of scrape some of that off as well. Okay. The next step is to set up your sterile field. So opening your drape, you want to make sure that you try to get the end corner because the 2-inch border is not sterile. It's not considered sterile. That's the part that you can touch, right? Sometimes if you open the package all the way, it just like flops out and lands on the floor. So I'm always really careful about letting it go too far. And it's really up to you how much you unfold this, okay? If you unfold the entire thing, it's about this size, but sometimes we don't have that much room. So if we don't have that much room, we can always do it in, you know, a half size. It's really wherever your room allows for, okay? Don't think that you have to open it all, because you don't. Okay, at this point in time, I'm ready to go ahead and don my sterile gloves. Sorry. We're gonna go ahead and open our packages. They're already open, so go ahead and get all of our material out here. We will pretend that these are in a sealed container too, and that this is in a sealed container. And if that happens to you, just throw it away. Get a new one. Sometimes these are difficult to get open. So everything sterile is on your field now. You can open up your water. If it's a new bottle, you don't have to lip. If it's not, you need to. Okay, so we'll go ahead and don your sterile gloves. So the sterile gloves are on now. You'll go ahead and start by packing the tunneling area. So you'll use your scissors to hold down the bottle and your forceps to pull up. And when you cut, you want to make sure that you cut enough to where you leave enough for the next person, but you don't leave enough to where it flops over the jar, okay? If you have multiple sites to pack, you can lay them down and get another one and lay them down. Or if you only have one, and we're just going to demo one, then you can go ahead and just keep a hold of it and start packing, okay? So at this point in time, if you're going to use these again, you need to put them on your sterile field. If you're done using them, you can set them aside. Okay, so it just depends on how you want to continue. Some people will use this to put this in, some people use their finger. Doesn't matter. It's however, you're all sterile. Everything's sterile. So it's whatever. If these don't clamp real well, I wouldn't recommend it. I'd probably just use my hands. Okay? You're going to pack that wound and then leave your tail.
Did you dip it in anything?
Nope. I always just kind of work with this a little bit so that you can get the most out of it. You can use the cotton tip applicator, a different one, to help kind of get that under the wound edges. Four by fours. At this point in time, the sterile part of this is over. Your ABD pad goes on. Don't use more tape than you need to. Only go around the border, the edges of the border. Go around the edges of the pad. No more than you need to. This patient's already breaking down skin-wise. We don't want to add any more complications. I always make this 2 pieces. Sticks a little better. Name, date, time, and initials. Or initials, date, and time. Any questions?
How about the bowl? Is the bowl sometimes sterile as well?
The inside of the bowl is sterile, yes.
Okay. But the bowl itself is never sterile.
Unless you put it on your sterile field. Now, if you open it up and decide to drop it on your sterile field, then it becomes sterile.
Okay.
If you just open it up and grab it by the outside and bottom, and you set it on a non-sterile area, only this inside is sterile then. Yep, good question. Anybody else? Yes.
When you put the tunneling strips in, you said you can use your finger to like actually.
I use my finger to hold it and use the cotton tip applicator to shove it.
Okay.
Yes, because I have found that these, you're over here, you're getting it like halfway through and it drops. And you're like, crap, you gotta pull it back out. That's just how in the nursing world, these plastic ones, they're junk. They really are. But you really need the metal ones to get a good tight grip on something that thin. Yes.
So the dry wound dressing skill we have is all of that, but we just don't pack it with anything, right?
Correct.
Okay.
Yes. In essence, that is exactly right. You will go based off the orders. You're going to clean it still. So let's just say that it's sutures or staples. You're going to want to clean that. Take your pre-filled syringes and squirt that. Clean it really good. If it's asking for Hibiclens, if it's asking for CHG, whatever type of cleaning product it's asking for, clean it, and then put your dry dressing back on. You can use your 4x4s and then put an ABD pad. You could use, if it's a pretty good sized wound, you could even use Curlex, kind of go up and down it. Like open heart, for example. You could kind of go up and down versus putting 5,000 4x4s on. Okay, so it's just kind of whatever that patient, once you assess it for the first time, you're going to kind of see, you know, what you want to use for that patient. So there's many times that I go in and I take that, I have all the stuff I think I want or need, and I go in, pull off the dressing, and I'm like, oh, this could have been done totally different with and better with these supplies. So the next time when I go in on my shift, I'll take what I want in and do it. So it's just the first time that you see the wound for the day, that's a great time for you to decide what supplies you need. Kind of going in blind or looking at the last person's charting, which sometimes could be great, could be not so great, and you're kind of going off that. Yes.
Just to repeat, so the label tape should have time, date, and initials, right?
Correct.
Because
Yes.
the skills checkoff says name, date, and initials, and that doesn't make sense to me. So.
Yes.
Okay,
Mhm.
I think it's a typo.
Yeah, I agree with you. I think I said it that way too. So
Okay.
yes, so it's your initials, the
Yeah.
date, and the time. Mhm. Good. Yes.
Is there like a little bit of flexibility then? You have the order that dictates kind of what supplies, or it just depends situation to situation?
It does depend situation to situation because there are so many new types of wound dressings out there on the market now that if they tell you wet to dry, it's going to be more than likely just what I did. But there's so many new things out that have medication in them. There's wound vacs now, so there's so many different things that are proving better than just the standard wet to dry, but this is the very basic. When it comes to new things, I don't even know all of those. A wound nurse probably would be very educated on them, but we have so many wound nurses now that nurses aren't quite as educated on the new products because there are wound nurses. Or when I started out in nursing, we did all of the wounds. There wasn't a wound nurse. So we were starting to learn the different types of treatments and dressings that were coming from manufacturers. But now there's so many new ones that Omnicell is just full of them. And I don't know half of them now because, you know, we have a wound nurse who takes care of it. And realistically, that is the best for the patient. If the same person every day or the same team every day is coming and taking care of that patient, then they're measuring the exact same spots every time. They're charting exactly what they saw the day before versus somebody new charting, because my scant amount of fluid is different than what your scant amount of fluid could be by, you know, ever so slightly, but you get my point that charting is opinionated, and if the same person is doing it over and over again, the continuity of care for this patient is truly better. So wound nurses are a good thing. So,
When
okay.
we're checking residuals, how do we know like when to stop? Like
When you start getting a lot of air.
okay.
So when you're not getting any more fluid, then you've pretty much removed all of the contents. Mhm. Sometimes it'll be your whole syringe, right? So then you have to, unfortunately, this gets a little messy then, right? Because you're going to start squirting it back into here. So if you pull up that whole thing and it's an entire 60 cc syringe full, you're going to have to dump it somewhere, right? So unfortunately, you're going to have to get rid of this and dump it in here to keep sucking, because I'm sure you didn't bring in 5 syringes with you. Okay? Good question. Anybody else? Okay. I'm just going to go ahead and go into trach since we're right here. Is that okay? I was going to give you guys a little bit of a break, but I'm just going to keep going.
Let me get my phone. Good connection.
Let's see here.
Could you put that at the foot of the bed, Jessica, you think?
Oh,
That might get a pretty good angle.
yeah, I'm just trying to get the bedside table as well.
Oh, I see.
Yeah.
I see.
Ideally, whatever side your suction's on is where you want to be, but since you guys are recording, I'll just do it on this side. You want to go ahead and turn on your suction.
What did you just say about what side? I'm sorry.
Decide with the suction, so you didn't have to just reach over the patient like I just did and suffocate them. So you want to be on the right side.
number the suction should be on?
So you should have it about 125. Anywhere between 120 and 150, but generally speaking, you'll see them set about 125 when we do suction. So the patient, you want to make sure they're hooked up to oxygen so that we're able to hyperoxygenate them. Keep in mind that for demo purposes, I don't have any oxygen tubing right here, so we will just simulate that process. Let me get all my supplies here. So you're going to have a trach kit and a suction kit. It's kind of two different skills in essence, okay? Always look and see what's in your suction kit or your trach kit before you go into the room to start the process, because it may not have gloves in it. It may not have fluid in it. So you just need to kind of look and see what's in them. So in the kits that you'll have, you have sterile gloves. You have a drape that you can use. I like to use this drape sometimes. It just depends if I'm doing trach care and suctioning at the same time. Okay, the one that's in the trach care I think is a little nicer, so I tend to use that one when I'm doing trach care. So you'll just go ahead and knock this down for edges. Shiny side goes down. Doesn't always cooperate with you real well sometimes. But remember, you have that 2-inch border. This is really the part that you need to keep sterile, is what's in here. Okay, so you can go ahead and put it on your sterile field. And these, for the most part, will stay coiled for you. They stay pretty coiled, where like the Foley catheters, when you open those, they like start flopping everywhere. So these will stay coiled on there for you pretty nicely. And you have your water in here, okay? You can choose to either pour it into your basin, because this is all sterile, or you can choose to just take the top of it off, and inside this you'll see there's a little circle. It'll generally sit right in there for you, okay? Now, because I've put this in here and it wasn't sterile, this is not sterile anymore now. Okay, so I'm picking this up. The only thing that's sterile is the water that's inside of it. And you can sit this on the patient wherever you really want to put it. It's spilled before. I've had it spilled before. Unfortunately, tell a patient not to move, and you're going to suction them and they move a little bit. So just be aware of that. You can use a bedside table if you want. It's whatever you're most comfortable with. I'm just going to put it down here so that it's all in the same area for you guys. Next, you want to go ahead and put your don your sterile gloves. If you know that you are larger than a size medium glove, I would recommend just bringing in your own sterile gloves. When you put sterile gloves on, take your opposite hand and reach in and grab the opposite glove on, if that makes sense. So you're going to take my right hand, it's going to grab my left glove. So grab it by the cuff, and as soon as you get it, like pull up on it quickly. Because if you don't, you could slide it across the table. Okay, so just make sure you go in, pull up. You want to do gloves up here, don't do gloves down here. Okay, so when you're up here, palm of your hand is up. Don't mess with the cuff, don't mess with anything here. Just pull it down to where it stops and leave it, okay? You're gonna take this hand, you're gonna go under the cuff and just pull up quickly, okay? Go in, palm up. And I always encourage students to move this thumb, because if you leave it here, you end up hitting and contaminating, okay? So move this finger out of the way. Sometimes they cooperate with you and sometimes they don't. can touch your hands, but nothing below your wrist. At this point in time, you're going to determine, okay, what hand am I going to keep sterile? Okay, I'm going to make my right hand sterile, my left hand not sterile. So we've hyperoxygenated the patient. We're going to go ahead and connect the suction. This is my sterile hand. We're going to make sure that this is going to work appropriately. Yep, it's working great. Okay, so at that point in time, you could go ahead and remove the oxygen. Go until you feel resistance, or they start coughing, and then it's back out. Okay. Clear your line. All of my secretions are out of my line. Get resistance or cough, back out. Clear my line. We could do it a third time. Okay? Any questions about suctioning? Pretty easy, right? There's only, just got to remember that you have one hand that's sterile and one that's not. And that sterile needs to hold on to only the rubber part of this tubing. And when you're oxygenating and you're giving this patient a break, that you just hold it out here and make sure this doesn't hit anything. Okay? And then redo this and redo this.
How do you hyperoxygenate? Do you just verbalize that, or do you?
You can. You can just tell your instructor that, or you can actually take your hand and put it on here and say, I'm doing this skill, this part of the skill, and back over. If they don't have one of these here, you could just announce it.
And then do you ever turn off the thing over there?
The suctioning?
Yeah.
Yes, you'll turn it off as soon as you're done suctioning.
Okay.
Yep, so right now we would be turning this off. Okay. Any other questions? All right, good. Oh, yep.
Did you pulse? Are you pulsing? when
Yes,
you're pulling
as
out?
you're coming out, you are. Yes, it's intermittent suction on the way out. And it's pretty quick, right? You're not like taking your good old time to pull that out. You're getting out of there quickly. Good. Any other questions? All right. Will you just turn that off for me? Yes. Okay, so in your trach kit,
So doing this really would change your sterile gloves part
Yeah.
between it.
in between doing the next part, yes, because you only have one sterile glove, and you are more than likely going to want to.
Okay.
Okay, so inside the kit is your sterile gloves, and a very similar but a little bit thicker, a little nicer. If you open this kit first and you decide to use this one first, you could potentially just leave it as long as you keep your eye on your sterile field. Okay. And then you can choose to either put your stuff on your patient, or you can choose to put that field somewhere else. I just like to do everything up here. Okay, just is easier for me. So the contents that are in here, let me just show you what they are. You're going to have your split dressing. It's going to be dumped on here. You're going to have some 4x4s so that you can clean your face plate with. Those are going to get dumped on here. You're going to have pipe cleaners. You're going to have cotton tip applicators. You're going to have a brush. And you're going to have these ties. You rarely see these anymore. We now pretty much see Velcro. We don't see too many ties. And the reason why is probably similar to how some of the trachs that are in here are tied. They're not tied like in a knot. They're tied like like your tourniquet, to where you can undo it quickly. All right. Never take trach ties completely off before having new ones on. Okay. If a patient would cough hard, they could potentially, have that trach come out. So make sure that you have the trach new ties on before you take the old ones off. Okay. All right. So I'm just gonna. This has a Velcro one, so I'm just gonna bypass this for right now. All right. Next, you're gonna want to make sure that you have some type of sterile water so that you're able to clean this. You can use this here as your sites. There's 3 parts to this. So if you fill, you need at least 2 of them filled. A lot of times people will just go ahead and fill all of them because once you have your sterile gloves on, you really can't touch it again, right? So this is a good soaking spot, and one of these is a good rinsing spot, okay? So this is brand new. Couple different ways to do this. You can at this point go ahead and take out the trach that's in here. This is a disposable one, so this skill eventually I think will go away, but we still have to teach you it because there are patients who have reusable ones. This one is not. So literally this skill would be remove, trash, open a new one, put it in. But because there's some that are still hanging around with these, we need to teach you how to clean it appropriately, okay? So these go in the same, they actually have like a little, you pinch and it releases them. These have a locking device. So when you put it in there, you turn it and it locks. And then you unturn it and pull it out. And like I said, these ones are just, you just squeeze, okay? These are inner cannulas. The outer cannula is still in there. It's just this, oops, excuse me, this part of it. This part of it that you're disposable or cleaning, okay?
And you're wearing clean gloves for this receiving?
Yep.
Okay.
Yep, you can just take, you can just use clean gloves right now if you're choosing to take this out and just have it soak, okay? Some nurses you'll see that will go ahead and contaminate one of their hands after they get their sterile gloves on, just like they were with suctioning. So they'll go ahead and remove this because this part of it is not sterile. It's this part that's sterile. So when you put this in somewhere to clean, as long as you're picking it back up with the hand that you already contaminated, it's fine. So it's just a matter of preference of how you want to do it. So you can either take it out and drop it in and let it sit and go ahead and sterile up, or you can go ahead and sterile up and take it out and have one hand that's not sterile. Okay? Whatever preference is. All right, so we're going to go ahead and don our sterile gloves. Reach in, grab. Okay. At this point in time, we need to clean what's in here. So you can either choose to use, you can either move this to the patient, or you can just work in this area. Whatever you want to use as far as cleaning. So you can use pipe cleaners. And it really just depends on how much secretions are dried in here. Sometimes you'll pull them out and they look pretty clean and you really don't have to do a lot of cleaning. Especially if you just suctioned, it's going to be way easier.
Is your left hand now not sterile?
Well, technically, it shouldn't be, but it still is.
It is sterile.
It is sterile.
In theory. Or whatever.
I guess the rationale behind that is it's in sterile water. So, I don't like to cross-contaminate. So once I touch this, I won't be like this. I just will keep my hand on this end. After you clean, you can choose to use the brush. If there's anything else on it, this brush won't go up inside here. You really need to use the pipe cleaners for that. But sometimes they get kind of like a little bit of gunk right here that you might have to actually use this brush for. Okay.
Do you rinse it at that point?
Yep, you're gonna rinse it. Sorry. Yes, you're gonna rinse it. Get all of those out, and then you can go ahead and go right in. I always like to go in kind of at an angle and then drop it in. because I feel like if I aim it this way and you're pushing, this can hit really easy, and that's, you know, contaminating your site. So I always try to go in here, and once I get it actually in the tip, then I turn it and push it in. It's just preference. It's just saved me a lot of times from having to re-clean it. Okay? Questions? At that point in time, you can clean your face plate. We're not going to go through those steps right now. So you can use this to your third slot there. You can get it wet. You can take your fluid and pour it on it. However, there's no more sterile anything now. So you can clean your face plate and then change out your ties. Okay? I would keep one of these to dry it off. Okay? You want to keep at least one to dry it off. And then you'll go ahead and put your dressing back in.
Does that have to be sterile or just?
No, nothing is sterile now.
Okay.
The only thing that was sterile was that inner cannula. Questions?
Where did you place the last pad? What was the last pad thing you were doing?
This is your split.
Okay.
So your split goes either this way or this way. There's not a right way, so it doesn't matter if it's this way or this way. It's whatever really the patient prefers. Most patients will prefer it this way, but some actually like it this way because, especially if they have a beard, they prefer it this way because it doesn't like get down into that that trach area and irritate as much. So it's really just what, you know, and the patient will tell you if you do it wrong the first time. They'll say, "Could you turn that around?" Yeah. Yes.
So that's the changing of the pad is the very last thing that you do. Is that correct?
Yes and no. What I mean by that is some people will go ahead and put the pad in and then change the trach ties, and some will put the trach ties on and put the pad on. There's not a right or wrong way. The only part that is that you could do incorrectly is breaking the sterile technique of this skill. Yes.
And changing the ties, you said you tie the tie on both sides of the faceplate before you take off the old tie? Or no?
Technically, you only have to do one side,
Okay.
but I've never had a tray come out on me, and I don't ever want it to.
Right.
So I go ahead and tie both sides.
Okay. So they'll have two ties on at once, and then you take the old one off?
And it's a little tight sometimes to get in there, but you can do it.
Mhm.
There's room for it. I always put two on. They might not be secure right this second, but they're on, and then take that other one off and then tighten it up. I just don't want that to happen to me. Hasn't happened in a long time. I never wanted to.
That's not part of our skills, though. I don't think.
Taking the ties off, it should be very
Is it?
It should be, yes.
Oh, okay.
Yep.
After you rinsed the cannula, do you dry it or no?
No, you don't have to dry it.
Okay.
Nope. Good question. So you're taking it out, cleaning it, and putting it back in. That's the sterile part of that. That's it. Once that's back in, you're not sterile. You don't have to worry about anything anymore.
Can you just demo one more time the taking off the thing
Taking off the
or putting on the new?
the trach, the ties. You mean?
Yeah, tie. Sorry.
I don't have another one, so I'll just have to take this one off. It's just Velcro. So what you would do is you would go ahead and put the other one on now,
Okay.
and then you would take this one off, and it's just let me just take it off so I can show it to you guys. So it's just a piece of Velcro that goes around. So literally, it's going around the patient, and you have these two little pieces here that go into the faceplate and then pull back and Velcro.
Okay.
Okay? So I just always try and, if I have one on already, I'll go ahead and even loosen this one, but get it in there. So you can loosen it because this right here comes off. Okay, this is like how you loosen it. So I'll put it down here even, for example. Some nurses feel like right now is easier to put this in. Now, some nurses will wait to the very end, pull it out, and put a new one in. There's not a right or wrong way. It's whatever you prefer. And this just loops in here, and you just pull it back. So I'll just put it on there loosely. So it's secure right this moment. It's not going to go flying out on the bed. it's in there to where I can get the other one off, and then as I take this one off, I'll tighten it. And as I get this one off, I'll go back here and tighten this.
Okay, thank you.
Mm-hmm.
And that's gonna be in the kit, a new set of that.
This won't be in the kit.
Oh,
These
okay.
Velcro ones won't. You have to get them separately. The ones that'll come in the kit are these.
Okay.
Okay, so you can just, whatever instructor you have, you can verbalize that you're doing this or this, whatever. I don't know what you may get this guy and he's got ties on him. So just verbalize them. You'll be fine. They're not gonna not pass you because you didn't talk about Velcro versus ties.
But there's something in the kit.
Yes, these are in the kit, yes. Mhm. All right, any other questions about any of those skills? Okay. Do you want a 5-minute break?
Yes.
Okay, take a 5-minute break.